Thank you, Mo, Mr. Chairman, colleagues. I've been asked a couple of weeks ago by Go Wakabayashi to give this talk, and I accepted with a lot of pleasure, even because I was leading one of the working group on the hottest topic, which was and is live donor hepatectomy. So why the second consensus conference on laparoscopic liver surgery? For two reasons. First of all, is defining the role, the current role of laparoscopic liver surgery. Secondly, to develop recommendation and guidelines. But let's go first to the Louisville expert consensus 7 years ago, which involved 45 liver surgeons, 11 countries, and you see that most of the surgeons were also coming from the US. The international position was published in Annals of Surgery in 2009, and there were different topics discussed. First of all, focus on standardized terminology, the current status of the liver surgery at that time, and further discussion on indications, operative approach, and so on. You can see here listed on these slides. Whereas the second consensus conference meeting in Morioka, the middle north part of Japan last October, same equal number of surgeons, for each coming from a different institute. And you see here the spread, the nationality of the experts, and there were also 250, more or less 250 delegates. And this is a group picture of most of the participating people, even delegates. And you see on the bottom right side, the oldest interested Japanese surgeon. He's 78 years old. The recommendation coming from this consensus conference have been published this month, April, in Annals of Surgery. And this is a slide showing the participating people in the organizing committee. So as I said to you, Professor Go Wakabayashi was leading the surgeons, and the organizing committee choose the expert panels. So any of these surgeons was leading a working group which was composed by 3 to 7 experts on a specific clinical question. But the difference between Louisville and Morioka is that the second consensus conference has been established with the Zurich-Danish, according to the Zurich-Danish Consensus model, which is a jury-based consensus, meaning that the organizing committee choose jury and experts. The experts are discussing specific clinical questions, and they give their final report to the independent jury. And this is the independent jury which is finally giving the recommendation. So there are not experts, like in Louisville, giving recommendations, but the jury. This is the main difference. And you see here the list of the jury. These gentlemen were not only experts of liver surgery, including transplantation, but were also experts of methodology, research methodology, surgical complications, innovation in surgery, and expertise in the consensus conference methods. This is a picture of the jury. The jury was on the first row, and you see here Professor Kokudo attacking me in lap liver donation. But I'm just kidding. He was very, very kind with me. And this is a slide listing the 17 clinical questions, which were mainly based on risk and benefit of laparoscopic liver surgery and techniques. So there were 17 working groups for asking this specific issue, but the jury was evaluating and giving recommendation only on 7 clinical questions, which are highlighted in red. How were the outcomes evaluated? So the jury tried to be very balanced, and they used 3 different methods. First of all, the grade classification, which is mainly based on the available literature data and methodology, was chosen with a score system moving up or down according to different factors. First of all, the large treatment effects of more than 50%. Then the jury identified, in agreement with the expert, a list of comparators. And finally, for evaluation of the evolution of the surgical innovation, the Balliol classification was considered according to the ideal guidelines, but I will come back on this. And the jury gives recommendations. So the recommendations were of 2 types. Type A, which were concerning the quality of body evidence, benefit-risk ratio, benefit-cost ratio, or patient preference and values. And upon the decision of the jury, these recommendations were scored as moderate or weak. And the type B recommendations were concerning the future steps to be undertaken, and this was classified as strong or moderate. You see here the list of comparators. The most important judged by the jury were mortality, complication, margin negativity, overall survival, parenchymal sparing approach, cost and indication, benign versus malignant. These 8 comparators were scored for equality using an utility score going from 0 to 10, and according to the jury, so you have on the second column the mean of this score, and the following comparators from blood loss to incisional sequelae were evaluated for superiority, and this makes sense because this is probably most attractive benefit of laparoscopic liver surgery. Then the Balliol collaboration was used to evaluate in which stage the different procedure and outcomes could be graded. The Balliol collaboration was studying evaluation of stage, challenging evaluating surgical innovation, and giving finally the ideal recommendation, and this was done 6 years ago. And you see here the 3 main papers published in Lancet speaking about the rationale of this collaboration. And ideal stands for, as an acronym, stands for innovation, development, exploration, assessment, long-term follow-up. And for each of these categories, you have a specific situation of the stage of the evolution of the procedure. You can see that the initial stage is a proof of concept or is represented by case reports, and the most important and most advanced is long-term follow-up, which is showed by the surveillance of procedures, so the data coming from registry, or RCT on long-term results. And this is a representation of the 5 stages. You see that for what is concerning the final recommendation coming from the jury, most of the outcome and the results were staged as 2B and 3, so exploration phase and assessment phase. No possibility was found for stage 4 to attribute stage 4 to the evidence, actual evidence on the literature. This is a well-known S-curve model for representing the surgical innovation. And you can see after the beginning of a new concept, you have a tipping point. And the tipping point is representing the onset of the peak of adoption of a technique. And this is more or less, for surgical procedure, considered to be around 10 to 20%. And the next slides show the situation of adoption of different laparoscopic technique. You see that the best scenario of the fastest growth of an innovative procedure was the case of laparoscopic cholecystectomy, which in a couple of 2 or 3 years raised a very important percentage of performed cases. A little bit different was for the fundoplication or other procedures like hysterectomy, nephrectomy for benign disease or cancer. So there are different adoption curves. The best intuitive is the curve of laparoscopic cholecystectomy. Maybe more straight is the evolution of donor nephrectomy, laparoscopic donor nephrectomy. But for which is considering laparoscopic liver resection, we have probably not one well-defined tipping point, and which makes sense because there is an intrinsic difficulty of this procedure. So what we evaluated during the second consensus conference was all available data on this issue. And you see that, unfortunately, no RCT were and are still available in laparoscopic liver surgery. So most of the evidence, low-level evidence, is coming from case series, case match studies, meta-analysis, and some reviews. I get a look to clinicaltrials.gov 2 days ago, and I found just 8 running procedures on concerning RCT in lap liver surgery. I'm sure that the first one, the Oslo on colorectal liver metastasis, will be the first randomized controlled trial in the field of laparoscopic liver surgery. But we are also improving for the Orange 2 Plus trial, which is comparing open versus lap major hepatectomy. It's also surprising, but not really, not completely, that there are a lot of study RCT proposed by Chinese colleagues. Once back to the Louisville consensus and Louisville expert meeting, you see here the survey coming from that congress. And according to the survey, there were 45 versus 49% of benign and malignant liver resection procedure performed. The pure laparoscopic was performed in 3/4 of the cases. And at that time, 15% were the major resection, major lap resection. So what happened the last 6 years? You see here, we have today more than 9,000 cases published. There is a conceptual changes which has been implemented, meaning the caudal approach of the liver hilum, especially for major hepatectomy or anatomical resection, a better management of pneumoperitoneum and bleeding, and selective inflow occlusion by Pringle maneuver. What we learned also is the possibility to perform anatomical resection by laparoscopy, and on the top of this ideal pyramid we have the pure laparoscopic donor hepatectomy. This is the spread of the centers, worldwide spread of centers performing lap liver surgery, and you see that Western Europe, East Asia, and the US are the most active. There is the most active center performing this procedure, especially more than 100 reported cases. When we look to the series which have been reported in the literature, we see the exponential growth from the last 5-6 years, especially the combined minor and major hepatectomy. And when we look the case per year, liver case per year, we see that the last 2 years, 2013, 2014, there was an amazing increase of major hepatectomy by laparoscopy. This is the graphic showing the evolution of this resection according to the different kind of technique and of resected segments. Wedge and non-anatomic resection are the most performed procedure, which makes sense. But you see then we have the left lateral sectionectomy and close right or left hepatectomy. So this is witnessing an improving of the technique and also the expertise to perform this major procedure. You can see that 70% of procedure are minor hepatectomy, whereas 24% are major hepatectomy. This is a graphic concerning the malignancy. Most of the resections have been or are done for HCC. You can see at least 50% of malignancy are hepatocellular resection for hepatocellular carcinoma, non-anatomical but also anatomical resections. And this is the case of benign liver disease. It is a little bit surprising that 24% of this resection concerning benign liver lesion were unspecified. And you can see that the classic indication as adenoma, hemangioma, F and H are roughly ranging from 6 to 9%. Important is that 3% of this procedure are concerning laparoscopic donor hepatectomy. So what we know about 9,000 or more cases, the mortality is very low and equal to open liver surgery. The morbidity is much less, it's around 10%. The conversion rate is stabilized around 4%, which was also the case at the time of Louisville conference. There is a decreased transfusion rate, a decreased pain, hospital stay, early return to activity has been acknowledged. This is one of the main issues of the lap liver surgery, and the costs, which are intentionally decreased by a selective choice of the armamentarium, which which is available. More important on the oncological outcomes is that the margins and overall disease-free survival are identical. Of course, we are speaking about selected patients, but this is important because it's an oncological results. And last but not least, and this is especially for colorectal liver metastasis very important, is the early access to chemotherapy, which can give an additional benefit to oncological patients. And finally, we know that we can easier do a reoperation. We know what happens after laparoscopic liver resection for HCC and staged liver transplantation, or in case of repeat hepatectomy, when the first one is done by laparoscopy. We had some forest plot for comparative studies concerning the complication. LAP has significant less complications, significant less need of transfusion, significant less blood loss. There is a trend towards a higher operative time in LAP, which makes also sense. And hospital stay is significantly shorter as compared to open procedure. Resection margins, there are certainly about from the published data, no significant differences. For HCC, there is a trend toward the lower rate of positive resection margins in LAP approach. For colorectal mets, even a trend toward the low rate of positive resection margins, favoring laparoscopy. So finally, what are the recommendations done by jury? Minor laparoscopic liver resection is a standard practice, classified ideal 3 according to Balliol classification. Postoperative complication, length of stay were superior to open procedure, no outcomes were inferior. As I said to you before, the evidence is low, so we need additional studies to refine and to confirm this data. A little bit different is the case of major hepatectomy, which is still considered an innovative procedure, so ideal class 2B. From the literature, we see that length of stay is superior to open procedures, and other outcomes were not inferior. because of the low quality of the study, additional higher quality studies, including registry, which is very important, are important to define the role of lap liver surgery for major hepatectomy. When we look to the long-term outcomes, again, not inferior to open surgery, ideal 3 for minor hepatectomy, ideal 2B for major hepatectomy, and probably the best way is to get more results and to have a registry comparing not only LAP, but LAP with open liver resection. This is at least the suggestion of our jury. Concerning other recommendation, when we look to the robotic-assisted liver surgery, this is still in innovation phase, so ideal 2A, advisable, but to be done within IRB-approved registries. Donor surgery, difference between pediatric and adult to adult. For pediatric laparoscopic hepatectomy, they could put this procedure in the ideal to B phase, whereas adult to adult is ideal to A, still development phase, and this procedure shall be performed under institutional ethical approval and, again, reporting registry. Last but not least, the education. A major focus of efforts is also required to determine how the laparoscopic skills needed for major laparoscopic liver resection should be obtained by trainees and HPB surgeons in practice. And this is finally our task as laparoscopic liver surgery, because the future of laparoscopic liver surgery is in our hands, if I can say. Expert recommendation. So experience in both open liver surgery and advanced laparoscopy are mandatory. And all the lap liver surgeon must begin with minor laparoscopic resection, which makes sense. The hand-assisted or hybrid technique can help in facilitating the dissection and the resection. You can think about major hepatectomy, right donor hepatectomy, or approach to the resection of posterior and superior segments. And a good management of CO2 pneumoperitoneum is also warranted. And we know that we can go up to 20 millimeter mercury for a short period of time, 10 to 20 minutes, to better manage the bleeding situation. Major hepatectomies, high level of technical skills are required, and there is a steep learning curve. This is the fact. And this is why there is an intrinsic difficulty of the laparoscopic liver surgery. So we have to discuss how to further implement the skills. So the recommendation for this is very strong. The same is also the attention that we have to pay to define a scoring system which have to be validated and which can guide us to the development of expertise in a safe way. So strongly recommendation for this. And this is the final picture with the jury and the experts all together. I thank you for your attention.